Okay. Well, good evening, everyone. Welcome to the May meeting of the Cleveland chapter of the Academy of Integrative Health and Medicine. I'm Peter Geller, co-leader of the chapter, along with Dr. Amy Sapola, who is right here as well, and Dr. Jacob Wolf, who I don't know if Jacob is here tonight, but he's our third. Thank you so much for coming. We're really excited to be presenting tonight, hosting tonight, Dr. Lise Alschuler. As everybody knows, I'm sure, Dr. Alschuler is a professor of clinical medicine at the University of Arizona, and she is also the associate director of the Fellowship in Integrative Medicine at the university's Andrew Weil Center for Integrative Medicine. Dr. Alschuler is past president of the American Association of Naturopathic Physicians, and she's a founding board member, past president, and current board member of the Oncology Association of Naturopathic Physicians. And she's been an invited speaker at more than 300 scientific and medical conferences. She's published dozens of articles, been a co-investigator on 5 research studies, written chapters for medical textbooks, and has co-authored 2 books, Definitive Guide to Cancer and Definitive Guide to Thriving After Cancer. She was recognized in 2014 as Physician of the Year by the AANP, and she has also received numerous other honors. And so I could go on, but instead of taking time, you can read her bio, more details on the website if you like. But I'm going to turn it over to Dr. Alschuler.
All right. Well, thank you so much. And thank you, Peter, for your invitation to be here and your very good organizational skills. I'm going to share my screen and get going here. So basically what I want to do, this is good, Peter? Got the right screen?
Yep, it's perfect.
Okay, perfect. All right. So we have a lot to cover, and I probably bit off more than I could chew for this time. So I'm going to go through my slides. I'm going to not summarize every data point on them, but really I want to give you kind of a broad brush stroke with enough detail that you can make this actionable. And I'm going to try to cover quite a few topics. I do have some disclosures, which I'll just put out there. I don't think that this has influenced the presentation that I'm giving you today. What I do want to do is just to context this and talk about cancer survivorship, generally speaking. Then I want to talk about some common after effects. Obviously, there are way more after effects than I will be discussing, but I want to talk about some common ones with some common evidence-based integrative strategies that you can utilize, and then talk about some kind of headliner ways to reduce the risk of cancer recurrence. So let's just orient ourselves for a moment and talk about survivorship. This is a growing population, which is good news, actually. The number of survivors are increasing, and they continue to increase. This is in part reflective of the fact that there are more cancers being diagnosed, but it's also reflective of the fact that more cancers are being diagnosed at an earlier, more survivable stage. And in fact, treatment is getting better for many of the common cancers. So there are more people surviving. This graph is based on 5-year survival. And of course, we want more than that. And that's increasing as well. 50% of cancer survivors are survivors of breast cancer, prostate cancer, and colorectal cancer. And the rest of the cancers kind of make up the remaining 50%. And these survivors emerge into their survivorship with symptoms. More than a third, generally speaking, have some degree of symptoms, and most people have more than one symptom as related to the cancer that they had and its treatment. So these are individuals that reemerge back into their life, but not as they were before they were diagnosed. They're kind of in a new normal, and they are a population of need. And there are, unfortunately, quite a number of disparities in cancer survivorship. This slide just highlights some of them. For example, African-American women have a 2-fold increased risk of breast cancer-related lymphedema. Cancer survivors who live in rural areas are 23% more likely to have psychological distress compared to those in urban areas. And colorectal cancer survivors who are in a lower socioeconomic status are 50% more likely to have clinically significant anxiety and depression. So and this is again, just a very few of a number of disparities. And I just want to highlight this because I'm not going to address this too much in this presentation, but I want to encourage us all to have an awareness of the fact that disparities persist throughout the continuum of cancer care, and we should keep that in mind in our patient population as well. There are a number of barriers to having an optimal survivorship experience on the part of survivors. Most of this is systematic, so there are system-based. So there's poor coordination of care. There's sort of this drop-off that happens when people leave the oncology setting, and there's not really a clean handoff, despite a lot of initiatives in survivorship care that started in the early 2000s. There's still this very disjointed movement from being in oncology care to not being in oncology care, and yet coming into that survivorship with a lot of symptoms. So this is an opportunity, I think, in many ways for integrative care. And these people come into survivorship with some very clear priorities, which are summarized here. These are across studies. So clearly people want to recover from their treatments. One of the scariest things about cancer is the fact that it has a high mortality rate, related to other diseases, but also that the treatments needed to increase the risk of survival are often very toxic. So people emerge into survivorship with a high percentage or a high degree of symptoms, and they want to recover, of course, from those toxicities. People are also very invested in trying to prevent recurrence. This is a highly motivated group of patients. These patients have been through a lot, and they certainly want to do whatever they can to not go through that again. And of course, they often emerge into survivorship with a sort of rediscovered appreciation for what it means to be well and the importance of being well and healthy. So they have a renewed investment in their overall wellness. So again, a beautiful opportunity for integrative medicine. And in fact, if you look at the word, remission, which, not all survivors actually are in full remission, but for the purposes of discussion at this moment, I want to just talk a little bit or focus on those who are in fact in remission, no evidence of disease. Remission, when you look up this word definitionally, it's yes, the remission or the absence of cancer, but it also means absolution, lessening, relaxation, release. And in fact, remission is really a time or an opportunity for people to step into a sense of releasing old patterns of behavior, old patterns of lifestyle, releasing old thought processes and expectations around what it means to live this life as a human being, and really to heal on a very deep and full level. So in many ways, I think working with survivors is just a beautifully fulfilling and enriching experience for the provider as well. And the general practitioner, I'm assuming most of the people on this webinar are general practitioners, not necessarily oncologists, but the general practitioner has a very key role in survivorship. I'm going to give you a couple of data points. This was a study that came out in the Journal of Clinical Oncology, and they found that patients who utilized primary care at least once in the first 6 months after they were diagnosed had a 36 to 57% reduction in their risk of mortality. And this study is so important because it really underscores the importance of addressing the person as a whole and not just focusing on eradicating the tumor. That just eradicating the tumor is not enough. If we really want to improve survival in terms of longevity, we need to address the whole person. And this is really where primary care comes in. So with that being said, I want to jump now to some of the major after effects of conventional treatments. I'm going to focus on insomnia, fatigue, and chemobrain, just to, again, to illustrate, some of the ways in which we can be very impactful from a primary care perspective. So let's first start with insomnia. The first intervention I want to mention is very important. I use this a lot. I find it to be very effective. These data points are not in the oncology population, so that hasn't been studied yet. Great opportunity for a study, but I found this to be very helpful in my survivors. So weighted blankets have been shown to reduce the rate of insomnia and reduce the experience of insomnia. So it improves sleep quality. And can improve it to the point where people no longer have disrupted sleep or even sleep latency issues. The weight of the blanket varies in the studies from almost 18 pounds to just under 4 pounds. Generally speaking, most recommendations are that the weight of the blanket should be about 8 to 10% of the individual's body weight. If people are shopping, they're not uncomfortable. If anybody's not ever used them, they're just basically a heavy blanket, but they're soft and comfortable. But the weight of the blanket appears to induce parasympathetic nervous system activity. It creates that sense of kind of being in a womb of security and relaxation, promotes oxytocin, all of which are associated with improved sleep. So weighted blankets would certainly be something to consider. Moving forward, in addition to weighted blankets, another really good recommendation to consider for insomnia related to cancer survivorship is the issue of morning light. And in fact, when cancer survivors have disruption in their circadian cycle, and I'll give you some data points on that in a moment, they will typically have fatigue along with poor sleep and more inflammation, which is associated with higher incidence of other issues, including other after effects of treatment. So it's really important to address circadian health. And one of the most important ways to do that is exposure to light within the first 30 minutes of awakening. This has been studied in a number of trials in people with cancer. I've given you 2 data points here. They're the sub-bullets. The first was breast cancer patients, and there was no increase in cancer-related fatigue. There were better circadian rhythms and improved quality of life in those using light therapy. The second study was cancer survivors of many different types of cancer. And in those survivors, the use of morning light reduced cancer-related fatigue to normal levels. There was mood improvement and better sleep quality. And we can do this through natural light. There's also lots of light boxes available. So this slide just summarizes kind of the type of light box to get, but essentially you want to get the light that it's not going to be quite as bright as normal bright sunny day, but it's pretty up there. 10,000 lux is sort of the general intensity level that you're looking at, and you don't want to actually have somebody staring right at the light, but instead angle the light so that it's affecting their eyes, but they're not having to stare at the light. Very well tolerated. Some people have a little bit of eye strain and headache related to that, but for the most part, it's just a very easy, low-cost intervention. This is the kind of intervention that I'll recommend to patients. I'll see them again in 3 or 4 weeks, and they report improvement in their energy. So it's pretty quick and noticeable by the patient. And I should have said this at the get-go, but up to 80% of cancer survivors have some kind of disturbance in their ability to sleep. So it's a very common side effect. So of course we think about melatonin. Melatonin has been shown in quite a number of trials to improve sleep. This is something we're all quite familiar with, I think. This is just a meta-analysis which essentially says, yes, melatonin as a supplement improves sleep onset latency, increases total sleep time and overall sleep quality. And this has been studied in the oncology population. In the oncology population, the dose that you'll often see is 20 milligrams. We don't know if that's the right dose. It's just the most well-studied dose that's been typically dosed at night. And the reason that dose keeps getting repeated in studies is because it's so helpful, not only in terms of quality of life, but in terms of survival. So when melatonin is administered as a part of the overall conventional treatment program or alongside that, there's an improvement in complete and partial remission rates, essentially a doubling of those rates. There's 1-year survival rate, again, essential double of 1-year survival rate, and significantly reduced by about 50% across the board. Chemotherapy, radiation therapy related side effects such as thrombocytopenia, neurotoxicity, and fatigue. So melatonin at that dose with those kind of results is the dose that's typically used, and there's not a lot of deviation from that. I will show you some studies in the survivorship population which deviates from the dose a little bit, but one of the things to keep in mind is that melatonin is definitely a sleep aid, but it also affects the brain in mood, and specifically seems to reduce depression in people who have had a history of cancer. It probably does that in other populations as well, but it's just that cancer patients have been studied for this. And this is an example. This was a study using 6 milligrams of melatonin given for 3 months compared with placebo. And these were in patients undergoing breast cancer surgery. And then the study extended into the beginning of their survivorship period. And there was essentially a risk reduction of 0.25%, which yielded a number needed to treat of 3. That's very low. And this was to reduce depression. So yes, they got some improvement in sleep, but the primary outcome of this study was depression. So exogenous melatonin, a couple of points on this. Number one, there is no habituation with melatonin usage. It's safe, it's well tolerated. There's no suppression of endogenous melatonin production with exogenous melatonin. Endogenous production is produced primarily in the intestinal system and in the pineal gland in response to light, and that's it. So there's really no effect of exogenous melatonin on endogenous production. There's no negative feedback like other hormones. It's an oirogen, which means that it enhances REM sleep. So that's very important. When people have insomnia, one issue is just the lack of restorative sleep in terms of all the functions that happen at sleep or during sleep related to gene activation and deactivation, autophagy, apoptosis, all that kind of stuff, which is important, of course. But another function of sleep is to dream, and dreaming is a very important mental clearance or kind of a detox of the mind. And lack of dreaming is associated with depression, with anxiety, with poor quality of life. So melatonin supports REM sleep specifically, which makes it even more impactful. It's a very quick onset of action, which for me is why I dose it generally when people are starting to get ready for bed or they're getting into bed. They may read for a little while, then they get really sleepy. Don't resist it, let themselves fall asleep. And that's kind of when it's most efficacious. And the dosage ranges typically from 1 to 10, and is in the oncology, that's the survivorship dosage. In active cancer treatment, the dosage goes up to 20 milligrams, and we're seeing really high doses now, which are interesting, certainly something we should look at, not yet evidence-based. So, you can make your own clinical judgment decisions on that. Okay, so moving off of melatonin, L-theanine is another go-to for me in the oncology survivorship population. We know that L-theanine improves alpha wave activity in the brain, which is the same brain wave activity pattern we see in meditation. So it creates that kind of calm, focused awareness, and that's ideal for people who are trying to sleep. It's ideal for people who have trouble staying asleep. And L-theanine, the way I use it most efficaciously is when people are sleeping, they wake up, they have a lot of trouble getting back to sleep. I recommend L-theanine at their bedside. They take, typically I recommend 200 milligrams at that time, and they typically fall back to sleep within 20 minutes, no problem. So it seems to kind of help calm the brain back down. Meditation in a bottle, basically. And it has been shown, in fact, to have some anxiolytic effects. Again, non-addictive, no kind of side effects that you would typically associate with anxiolytics. So L-theanine is another go-to for me in our cancer survivors for sleep. We're still on insomnia. And then, of course, magnesium, really important, particularly important in survivors. This is a study not necessarily on cancer survivors, but just illustrating that 500 milligrams of oral magnesium over 8 weeks improves sleep time, sleep efficiency, improved melatonin levels, sleep latency, cortisol concentration. Magnesium really works well. The reason I've highlighted this is that in cancer survivors, many of the oncology treatments deplete magnesium. So people often emerge into survivorship somewhat magnesium depleted. You can run, RBC magnesium. It may or may not show up there, but from a functional perspective, this is something that is, I wouldn't say universal, but common enough that should be on your radar, particularly people who are just achy after their treatments, because chemotherapy, radiation takes a toll. They're very dehydrating, muscles just don't work as well. Bodies are just not very comfortable as people emerge from cancer treatment. So sometimes just giving some magnesium, if for no other reason, to help resolve some of the myalgias that are occurring, can really help support sleep. And then, of course, it has a role in neurotransmitter synthesis as well. This is a study looking at omega-3 fatty acids, and they took some folks, these are, again, not cancer survivors, but I think has a lot of bearing on the cancer survivor population. These are, they took basically two different types of omega-3s, one high in DHA, relatively low in EPA, the other higher in EPA, relatively low in DHA, and then they gave olive oil as a placebo. And what they found, interestingly, was that the DHA increased sleep efficiency, so faster, easier to fall asleep, and the EPA resulted in feelings of being rested upon waking, so that the combination together appeared to be most effective. So I think we as clinicians would say, okay, let's make sure we give sufficient or relatively high doses of DHA and EPA to support sleep. This too is a nutrient that is relatively deficient or insufficient in many cancer survivors as a result of the treatments. So this is something that certainly bears consideration. Okay, so that was my quick overview of insomnia. Now I want to move into fatigue, a related phenomenon in cancer survivors. And I want to start with just the circadian rhythm. There's really two components to fatigue in cancer survivors. There's circadian rhythm disruption and mitochondrial dysfunction. So both of those have to be addressed in order for people to experience less fatigue. If these two issues are not addressed, people as a result of treatment can have fatigue for a long time, many, many years. It's not the kind of fatigue that can just sleep away. So it's really, in my opinion, a travesty that anybody who's been through treatment doesn't go through significant rehabilitation of their HPA axis function and their mitochondria, because they both need support after all that, and they can emerge into survivorship with much higher quality of life. So this is important for that reason. It's also true that circadian axis disruption is fairly common in people diagnosed with cancer. There's some thought that there's a little bit of prognostic implication there, a causative relationship such that HPA axis dysfunction appears to increase the risk of cancer. Clearly, cancer as an inflammatory, stressful, physiologically and psychologically event, if you will, and the treatments associated with cancer disrupt circadian axis and circadian health as well. So there's a relatively higher amount of circadian dysfunction in cancer survivors. Those patients with advanced cancer who have disrupted HPA axis, which we would characterize as a flattened circadian profile or hypercortisolemia with cortisol resistance, those patients have a much higher risk of premature death or death from their cancer than those patients with a nice, healthy circadian rhythm. So from a survival standpoint, it's very important to address circadian profiles. This has relevance in people who are no evidence of disease in their survivorship. If their circadian profile is not kind of corrected, or it doesn't go back into that nice rhythmic phase and they persist with circadian dysfunction, their risk for recurrence increases. So from just a survival standpoint, we need to address it. And we get the side benefit of improved quality of life when we address it. This is true in lots of cancer types. That prior slide was breast cancer. This is a study that Lorenzo Cohen and colleagues did on metastatic renal cell carcinoma, and they found that altered or blunting circadian health, that flattened cortisol rhythm or hypercortisolemia, was correlated with increased depression and was more predictive than even the staging of the renal cell carcinoma of death, more predictive of mortality. So again, emphasizing the importance of healthy circadian function. And then this study is colorectal cancer, and in patients with those with really good healthy circadian rhythm, they had a 5-fold or 400% higher survival rate at 2 years than those with flattened circadian rhythm. And these are the Kaplan-Meier curves. So this is the group that had the nice healthy circadian rhythms. You can see their survival is much better at every time point than those with flattened circadian rhythms in this group 4. So this is really a very important issue to address. And it's good because we have lots of things we can do to support HPA health and circadian health. So I'm going to start with exercise, physical fitness. I'm a big fan of exercise in cancer survivors. I'm going to give you lots of reasons for that in the next few minutes, or the time we have today, but this is one. So physical fitness buffers against stress-related disease because it tends to alter the physiological response to stressors. It has basically a hermetic effect. Even though exercise itself is a very stressful event, people who exercise regularly have a much healthier circadian pattern, or more circadian flexibility or responsiveness than people who don't exercise. And when we look at the data on exercise and fatigue specifically, whether or not this is mediated through the HPA axis, which I would argue it is in part. I think, of course, exercise affects mitochondrial function as well. So you would imagine from a mechanistic perspective, we would see clinical effects, and in fact, we do. This first data point is a systematic review and meta-analysis, and they were looking specifically at cancer-related fatigue and breast cancer survival, breast cancer survivors, and they found that there was an improvement in fatigue when exercise was at least about 45 minutes, at least 2.5 sessions per week. So basically, let's round up. So that means exercising for about 45 minutes, 3 days a week, will correlate most tightly with improvement in fatigue. And they looked at supervised exercise, and that was the most kind of linked, because obviously when people are in a class or have a trainer, they're more accountable to their exercise. They found that aerobic exercise was effective, as was resistance training. So a combination is effective. There's other data points that indicate that, and sorry, my reference is there, it's just kind of in the blue, but they indicated, also other studies have indicated that the intensity of the exercise is important, that the more intense, the more effective it is. So people really should always find the edge of their fitness and exercise at that edge. As they exercise more, that edge gets further out, and so their intensity continues to increase. So they're really just always exercising at the edge of their physical fitness. At least that's how I talk about it with patients. Okay, why am I not advancing here? Let's try that again. There we go. This is a summary of studies on radiation-induced fatigue, and the vast majority of studies, these are all big studies. You can see Cochrane systematic reviews in here, and lots of big studies show that people who exercise have much less radiation-induced fatigue, and the exercise, the earlier it starts in treatment, the better the effect. So if people exercise, even though they often go into radiation feeling tired because they've just been through chemo or because of the cancer, even then, if they start exercising to the best of their ability, they will have less fatigue at the end of radiation and through radiation than if they don't. But if they pick it up afterwards, they'll still get benefit. This is particularly true for breast cancer, somewhat true for colorectal cancer, and for prostate cancer. Interestingly enough, it needs to be very high intensity exercise. Men with prostate cancer who just do gentle walks daily do not get a reduction in their fatigue. With radiation, they really need to be exercising more intensely. And lung cancer does not appear to benefit from exercise in terms of fatigue. Now with yoga, which is not this kind of intense exercise, but yoga nonetheless does also reduce fatigue via different mechanisms. This, I would say, ultimately is positively affecting the hypothalamic pituitary adrenal axis and maybe some other neurotransmitter axes. But yoga is particularly good for reducing fatigue when it's done after treatment. When the studies insert yoga during treatment, there is an effect, but it's not a very large effect. However, if people pick up yoga when they're done with treatment, the effect is much more significant. And again, when people are in a class, it's most effective, probably because of the compliance issue. So speaking of yoga, yoga kind of falls under the category of what sometimes is referred to as relaxation exercises. So it's activity, but it's kind of more gentle type of activity. And there was a systematic review and an indirect comparison meta-analysis, which included quite a number of studies. And if we look at during cancer treatment, there's definitely, I've kind of given you the arrows for the things that have shown benefit that don't cross the confidence interval. So the confidence interval doesn't cross 0. So there's definitely kind of a favorable effect to all these different treatments. But if you then take out the studies that were small. So you just look at the better quality studies by size. The treatments that appear to be the most effective are massage therapy, kind of combine various types of relaxation exercises, yoga, relaxation, and aerobic exercise. So that was not a relaxation exercise, but it was put in there as a comparison. So, I mean, this is just really good data for us to know. It justifies our recommendations for yoga, which is also beneficial for a number of other reasons, reduces inflammatory cytokines, improves anxiety, reduces depression, etc. Okay, so back to circadian rhythm, kind of whip through exercise and activity. And of course, we think about nutrients that are good and necessary to have healthy circadian function. So we think about ascorbic acid, which normalizes cortisol and ACTH levels. We think about some of the B vitamins like thiamine and pantothenic acid in particular, which are heavily utilized in the adrenal cortex. Lipoic acid is very important because along with HPA axis activation, or as part of that, we get the sympathetic surge, which releases epinephrine, norepinephrine, interleukin-6, interleukin-1, all of which accumulate in tissues. And if they accumulate, and their half-life is long, they can stay in the tissue for several weeks. If they're not broken down effectively, they will sort of derange the physiology of those tissues and have been correlated with cyst development, other tumor developments, and things like that. So we want to help break down the catecholamines that occur in the context of stress. Lipoic acid is one of the best ways to do that. At the same time, in the brain, we want to make sure that we're supporting appropriate neurotransmitter synthesis, and that would be with precursors like tyrosine. And then phosphatidylserine is something that has been shown to blunt the ACTH and corticotropin releasing hormone response to stress. So that kind of peak we get in response to stress is down regulated in response to phosphatidylserine at a relatively low dose of 400 milligrams a day. So these are just some nutrients to think about when we're thinking about optimizing the HPA axis. This is a very recent study in vitamin C specific to hypercortisolemia caused by chronic stress. And they divide them up into various groups with elevations of cortisol, DHEA, and then they divided each of those groups into either 1,000 milligrams of oral vitamin C or just diet control. And they found that vitamin C reduces cortisol and reduces DHEA when they're elevated, whereas diet doesn't really do that much. So it was basically just proving what we know. Okay, now, of course, we think about adaptogens. I hope we're all familiar with adaptogens, but adaptogens are so important, so unique. I can't think of a cancer survivor in my practice that I have not recommended an adaptogen to. I have a little bit of a bias about this. I think all of us should be on an adaptogen every day, given the stress of modern living. But that aside, adaptogens normalize the body's response to stress. They, help bring physiology back into that homeostatic dynamic balance. They reinstate the negative feedback in the HPA axis, turning that system off, reducing the hypercortisolemia, which allows the circadian rhythm to be reinstated. And there are a number of adaptogens that are very uniquely suited to survivors. Remember, too, that most of these survivors are coming into survivorship fatigued, exhausted, depleted. So the kind of adaptogens that we want are adaptogens that will, yes, normalize the HPA and do all that good stuff, but have a little bit of an uplifting edge to them. So one of the things we would think about would be Panax quinquefolius, or American ginseng. And this was studied by Deborah Barton and colleagues. And in this study, the use of the American ginseng improved fatigue over placebo, and did that at 4 weeks and at 8 weeks. Siberian ginseng is another ginseng we can think about, Eleutherococcus senticosus. It's a little more warming if you're a TCM inclined practitioner than quinquefolius, which is kind of neutral in its energetics. But this too is very effective at improving the HPA axis resiliency, and at the same time giving people a little bit more stamina, more endurance, more resilience to infection, all issues very pertinent to survivors. Now, this has not been studied specifically in cancer survivors, so these are data points in other populations. This is just a study I put in here because when we think about adaptogens, it's important to recognize that adaptogens, yes, are working in many ways primarily on the HPA axis, but they're working peripherally, they're working systemically. And one of the things that adaptogenic plants have in common is their ability to increase physiological fitness, as demonstrated, for example, by VO2. And VO2 really improves with the use of adaptogens, and that's like a very sensitive marker of cardiopulmonary fitness. And in fact, you'll see that. So with adaptogens, people should therefore be able to exercise more effectively, more efficiently, should metabolize their foods more effectively, more efficiently, etc. And then I think my last adaptogen I want to mention is rhodiola. I like this one a lot in cancer survivors because rhodiola has a very significant, very well-measured antidepressant effect. And many people, again, come into survivorship. Yes, they're like, potentially no evidence disease. You would think on paper they should be happy, but many of them are kind of depressed because they've just been through hell and they're scared of recurrence. Their life is not like it used to be. All these things kind of come up. And so rhodiola is really good at relieving some of the depression. And furthermore, people taking rhodiola tend to experience more mental clarity, more motivation on a mental sense. So it's just a really beautiful adaptogen for cancer survivors. This is, again, not a cancer survivor population, but this is just a study, actually a systematic review of studies that show that rhodiola is very good at improving physical performance, and mental health across the studies. And then this is a study specifically looking at young, healthy physicians, and they found that the rhodiola reduced fatigue under the very stressful situations of being a physician early in one's career. So again, just kind of a demonstration of the effect of rhodiola. Okay, so that's all HPA. I mentioned earlier that with cancer-related fatigue, there's the issue of HPA axis dysfunction, and then the second major contributor is the issue of mitochondria. And mitochondria are very important to get resuscitated. There's some earlier work that has, in vitro work that has shown if you take a dysfunctional mitochondria, you plop it into a healthy cell, that cell will eventually become malignant. And the converse is true. If you take a healthy mitochondria, plop it into a malignant cell, it will re-differentiate into a healthy cell. So that's, of course, in vitro. But the point is that mitochondria, in many ways, determine the fate of the cell. So from a prevention perspective, it's important. And of course, as the major energy producing center in the cell, mitochondria are obviously underlying fatigues on a cellular basis, and then as it gets very widespread on a whole system basis. So when we think about mitochondrial resuscitation, I think about improving the antioxidant or the redox capacity, especially of the mitochondrial membrane, which is where a lot of the oxidative phosphorylation is occurring and generating a lot of oxidative stress, which over time, with the addition of the oxidative therapies of cancer, for example, can become overwhelmed, leaving a lot of damage in the mitochondria. One of the key components to good redox at the mitochondria is glutathione. This is a study by John Ritchie, and he demonstrated that oral glutathione, nothing fancy about it, just straight up oral glutathione, increases blood glutathione levels in proportion to the dose used. So the higher dose, higher blood levels. And when the glutathione was stopped after a period of about a month, the glutathione levels returned to baseline, again indicating a dose response relationship. And furthermore, there was a reduction in oxidative stress in people taking glutathione, as well as natural killer cell toxicity, cytotoxicity, which is highly glutathione dependent. This study is important because glutathione orally can be absorbed, and it is therefore an important potential oral supplement. You can also eat glutathione if you eat any fresh food that has not been processed. Will have a lot of glutathione in it. We can also certainly recommend precursors. Cysteine is the rate-limiting step in glutathione. However, I'm not a big fan of N-acetylcysteine in cancer survivors, only because there's been a couple now, maybe 3, studies in rodents, which have shown for whatever reason, specifically N-acetylcysteine appears to give metastatic cells greater metastatic potential. The mechanisms are related to the antioxidant capability, but that has not been shown with any other precursor to glutathione, lipoic acid or glutathione itself. So until we know more, I'm just sort of cautious about using NAC. I'll use it short term for respiratory issues or whatnot, but for long-term glutathione resuscitation, I prefer to go right to the oral glutathione or use other precursors like acetyl L-carnitine, or we'll get to lipoic acid in a moment. This was a study looking at elderly patients with fatigue, and they used acetyl L-carnitine, and they essentially found that there was an improvement in both physical and mental fatigue with the use of acetyl L-carnitine. That has been shown in cancer patients, people with cancer as well, using L-carnitine at a dose of at least 4 grams. So it's pretty well studied in that regard. Lipoic acid is also a very important precursor to glutathione and so important in oncology. This is just a kind of a study showing that when creatine, CoQ10, and lipoic acid were used in patients with very specific mitochondrial cytopathies, that the combination actually improved mitochondrial function, which is just not really related exactly to the oncology population, except to say that there is a role and that these, at least in this particular instance, these supplements have been shown to impact mitochondrial function. And this is really actually an area of needed research. There's very little clinical research out there looking at mitochondrial resuscitation specifically, and these nutrients, never mind in the oncology population. So kind of we're sort of in the land of empiric data. However, lipoic acid becomes a very important supplement to think about, because in addition to resuscitating mitochondria, being a very important mitochondrial support nutrient, alpha lipoic acid inhibits cell proliferation. It has a number of other effects within the cell that collectively essentially result in decreased signal transduction that otherwise pushes proliferation, abnormal proliferation. Also, lipoic acid improves apoptosis, which is cell suicide pathways for cells that have sustained overwhelming damage. And so there's some interesting data to suggest that lipoic acid may have a very unique and important role in cancer prevention. Lipoic acid, for example, changes characteristics of the tumor microenvironment, which is sort of the cellular environment or the tissue environment that is either permissive or not to tumorigenesis. And that has a lot to do with the oxidative nature of that tumor microenvironment. And lipoic acid helps to reduce the oxidation basically of the tumor microenvironment, therefore making it less permissive to cancer growth. So that's another way in which it's cancer preventative. It inhibits stem cell dedifferentiation into cancerous cells. So there's just a lot of mechanisms for lipoic acid, something I actually recommend for most of my cancer survivors. Okay, so with that, I'm going to go on to chemobrain. Chemobrain is my last sort of after effect of treatment that I want to highlight. This is a condition that is essentially an inflammatory condition. It's a neuroinflammatory condition. Other systemic inflammatory conditions like obesity will make chemobrain more likely and will make chemobrain worse. And so things that we normally think about improving cognition, particularly in a neuroinflamed environment or in a impaired cognitive state that results from some kind of inflammatory situation over a period of time, like dementia, for example, that's what we would think about using for chemobrain as well. So as an example of that, lion's mane mushroom, which has many mechanisms of action, but one of which is to, in fact, reduce neuroinflammation and improve nerve growth factor, specifically, has been shown to improve cognition in people with vascular dementia and in the elderly, has not been studied specifically in cancer survivors, but I will tell you from my practice experience, this works beautifully in people who have been through chemotherapy, irradiation, and have this kind of impairment of cognition. Works beautifully. And this is just an example of its ability to reduce depression and anxiety, primarily through its ability to increase nerve growth factor. Makes sense too, because it is a medicinal mushroom. So like all medicinal mushrooms will improve cytotoxic immunity, which is one of the main ways that we defend ourselves against cancer development. And for people who take at least 3 grams worth of mushrooms that are high in these polysaccharides, there's a 9% absolute reduction in 5-year mortality, meaning that there's 1 additional patient alive for every 11 patients treated with the mushroom or mushroom extracts. Low number needed to treat. So for that reason alone, it makes sense to use lion's mane mushroom. Plus, of course, you're getting the cognitive benefits. Along with that, I love citicoline in my patients who have chemo brain. This too works so well, works very quickly. People will notice the benefits within a week, typically in my practice. There's various ways in which this works, but it appears to improve essentially neuronal communication by improving the integrity of neuronal membranes and replenishing choline and acetylcholine. And in a Cochrane review, which of course is a very conservative review, they concluded that choline has a positive effect on memory and behavior in at least the short and medium term. That was because the studies were not long term at this point. This is just a poster that was put out by Cognizin, which is a form of acetylcholine that's available in many different dietary supplements. It's a branded ingredient. And you can see that the membrane turnover rate increases, meaning the membranes are more fluid, more healthy. There is an improvement in energy utilization, so more cognition occurring, and there's fewer omission errors in people taking Cognizin. And this was just at 4 weeks and at 6 weeks. So again, very quick acting, 250 milligrams in this study, 500 milligrams in this study. Curcumin is another one that I like a lot for chemo brain. Obviously anti-inflammatory, crosses the blood-brain barrier, so reduces inflammation, improves nerve growth factors to some extent, helps to clear amyloid beta plaques, which is obviously relevant as with anybody. And then L-theanine, I come back to that. This is, again, something I would think about for chemo brain, because this actually improves gating. So it allows the brain to not get distracted with all of the multitude of stimuli coming in at any given moment. The feeling of the chair underneath our butts, I'm looking out the window, I see that, I see this wall, I feel the desk. I mean, all these things, our brain just kind of like gates out so that we can focus on what we need to. L-theanine improves our ability to do that, which just helps people with chemo brain, because one of the challenges of chemo brain, or the aspects of it, is a difficulty focusing and really not able to multitask at all, or kind of track what we're doing very well. And then finally, resveratrol is something to consider. Resveratrol specifically improves hippocampal activity, which is in many ways where we form and store memories. So this becomes important long term. Okay, so with that, I'm going to move into cancer risk reduction. And this is obviously a huge topic, so I'm going to really just hit some high points here. But I want to just, do this because when we're thinking about optimizing cancer survivorship, yes, we need to address all the side effects that people are experiencing and the after effects, but we have to address risk reduction in everything we do, because that's what people are really concerned about, as they should be, right? I mean, they've just been through an experience that's very challenging. So I come back to exercise, because exercise is very important. This is a really pivotal study. And basically what the study shows, if you look at the risk of death from breast cancer, or the risk of death from any cause, you can see that people who exercise before their diagnosis had a pretty good reduction in the risk of death from breast cancer if they were exercisers before their diagnosis, and same for the risk of dying from any cause. If they picked up exercise after they were diagnosed, their risk still is significantly lower in most studies, and same risk of dying from any cause lower in most studies, which is very encouraging. This means it's never too late to start. If we look at the same thing in any cancer, not just breast cancer, we see that before diagnosis, the data isn't actually quite as compelling, whereas after diagnosis, wow, look at that, doesn't even get near the confidence intervals don't get near 1, highly statistically significant. So, picking up exercise after the diagnosis makes a whole lot of sense in terms of reducing the risk of cancer recurrence and, in fact, the risk of dying from any cause, which is important because a lot of people, for example, who go through chemotherapy, radiation, they may sustain some cardiotoxicity, even if it's mild. The risk of cardiovascular disease and death is slightly higher. And so these kind of data points are very important and relevant. Okay, and this is just another physical activity. Just this study is up here specifically to note that people who have other inflammatory conditions, like being overweight or obese, they have a higher risk of death, and their risk of death is compounded when they're sedentary or when they're not physically active. So the other end of being physically active is being sedentary, and we need to address that as well. When we're physically active, our muscles become more toned and they produce myokines, which are now associated with a number of anti-inflammatory effects, which is one of the reasons why exercise is uniquely impactful for reducing mortality, because of these anti-inflammatory results of well-trained and well-honed muscles. Myokines have been shown to also counter the adipokine inflammatory effects from fat. So we know that extra fat is carcinogenic, in part because the adipokines that are secreted, whereas, so even if people have carrying extra weight, extra fat, but they are regular exercise and their muscles are secreting myokines, the carcinogenic effect of the extra fat is somewhat mitigated. So it's really important that everybody be physically active. It's kind of the bottom line. Okay, what about diet? So obesity for sure is associated with the worst prognosis after cancer and increased risk of secondary malignancies. People are highly motivated, probably more motivated at any other time in their life after they've been through cancer, to adopt diets and exercise patterns that would support weight loss. So this is a good time to talk to patients about that. When people are overweight, because of the adipokines that are secreted, the inflammation that's generated, the change in gene expression patterns, both in the adipocytes as well as actually in other cells, we see a lot of carcinogenic things that increase. So there's at least 121 genes that change their expression in obese versus non-obese women. And the genes that are upregulated are genes that are involved in all these, what we call hallmarks of cancer, these components of cell behavior that make it more likely for tumors to grow. So unfortunately, extra weight is associated with increased risk of cancer. Along with that extra weight, or one of the key kind of translation pathways for that risk, has to do with insulin resistance. So when people have obese or hypertrophic adipocytes, and these adipocytes are inflamed and they secrete these inflammatory cytokines, including leptin and interleukin-6, tumor necrosis factor alpha, that these cells also become insulin resistant. So there's higher levels of insulin and insulin growth factor 1 in circulation. There's higher levels of growth factors like VEGF. All of these things are picked up by receptors throughout the body, and various intracellular tyrosine kinase pathways are stimulated. These are all very notable and known as carcinogenic pathways: the mTOR pathway, the MAPK pathway, NF-kappa B, because they're associated with various components of tumorigenesis or cancer development. So this is kind of just a graphic to represent the impact of obesity. And we know from various data points that this is a link, that insulin resistance is in fact linked with risk of cancer. This is a study that shows the risk of dying from various cancer types in diabetics. So people with diabetes have, you can see, a significantly increased risk of death from liver cancer, from pancreatic cancer, ovarian cancer, et cetera, pretty much down the line. Some cancers like connective tissue cancers not really showing an association, but for the most part, very clear associations with increased mortality in relationship to diabetes. And even just looking at fasting blood sugar levels, if you look at fasting blood sugar levels, in this case of what corresponds to over 100, you can see that there's a significant increase in cancer-related mortality starting here. So, you know, this is an issue we need to address. So we have to assess it first. I think that we need to get fasting glucose and fasting insulin levels on all our cancer survivors, plug it into the HOMA-IR calculators, and come up with your HOMA-IR level. I use 2.5 as a cutoff. Anything above 2.5 to me indicates some degree of insulin resistance. And when it's there, I address it. If it's not there, I'm not as concerned about it and I address other things. But if it's present, I definitely address it. So how do we address it? So one thing we can think about just from a nutrient perspective is intracellular signaling. We can influence that to some extent. So this mTOR pathway, which is a key growth pathway that's stimulated in part by insulin receptor activation and insulin growth factor 1 receptor activation, we can sort of down regulate the mTOR effect of these receptor activations when the cells have sufficient magnesium and chromium. When there's sufficient magnesium and chromium, this receptor activation tends to promote glucose uptake and utilization as opposed to mTOR activation. It's also true that we can impede mTOR activation by increasing AMPK, which is done by increasing berberine or using berberine and tocotrienols. Both of those will upregulate AMPK. So these are just some nutrients to think about. And then we think about, actually, let me go back. I don't know how to go back with this one. Go back for one quick sec here. I can't go back for some reason. Okay, so this is another kind of thing we can think about. Again, same pathways. If we use things like green tea catechins, we get improved insulin metabolism, better glucose utilization, and less activation of these proliferation pathways. Same is true with branch chain amino acids, improve the effects of or decrease insulin resistance essentially, and improve the cell signaling so that we have less disordered proliferation pathways. Resveratrol, capsaicin, fish oil, curcumin, ginger, all have been shown to do the same thing. So these are other ways that we can influence these pathways. I haven't even gotten to diet yet. So I'm just talking about some supplemental strategies to kind of optimize cellular signaling in relationship to insulin resistance. Now I'm going to get to diet. So I'm going to summarize this quickly to say that just ignore the mouse columns for a minute. Just looking at the human columns, if we look at the impact of these various diets on insulin growth factor 1, insulin, and glucose, which are the main things that we want to look at, we can see that things moving in the right direction with a calorie-restricted diet, a starvation diet, not a good thing to recommend necessarily. Some mixed results on protein-deficient diets unless you add the lower calorie component to it. Mixed results on ketogenic diet unless you add the lower calorie component. So essentially, the common denominator in these studies is a lower calorie diet, that lowering caloric intake lowers insulin growth factor 1, lowers insulin, lowers glucose, bottom line. So that is, in essence, next to the pattern of dietary intake, the most important dietary recommendation is to look at the quantity of food consumed. Now, we can do that with intermittent fasting of various types. This was a study looking at alternate day caloric restriction in overweight individuals, and they looked at alternate day caloric restriction, they looked at exercise, and then they looked at the combination. And essentially what they found was that only when exercise was added to alternate day caloric restriction did they see decrease in glucose, insulin, insulin resistance, and triglycerides. That's a really important takeaway, that, you know, it's not enough just to work with diet. We've got to address the physical activity component to all this. And remember, that has a lot to do with the myokines that exercise is causing the release of. Okay, so caloric restriction, however you do it, reducing the amount, reducing your daily intake by 500 calories a day, portion control, alternate day, or overnight fasting, however you do it, reducing caloric intake is important. And then we need to think about, well, what are we eating and how does that impact insulin resistance? And of course, carbohydrates come up. This is important, particularly in cancer recurrence. This was a study that looked at women with breast cancer, and they were able to go back to the pathology and find, look at the expression, the tumor expression of insulin growth factor 1. And they found that basically all the women who decreased their carbohydrate intake lowered the risk of recurrence. But in the women whose tumors had insulin growth factor 1 receptors, in those women who did not decrease their carbohydrate intake, their risk of recurrence increased 400%. So it's very important in some tumor types. We don't know which tumors have insulin growth factor 1 receptors. So therefore, I just treat every breast cancer as if it had insulin growth factor 1 receptors and really talk about carbohydrates and reducing quickly absorbed carbohydrates. There's some other data points that support this. This is a study that was out of the Nutrinet Sante study, and they found that sugar intake is associated with increased risk of cancer, mostly breast cancer, especially premenopausal breast cancer, but that it was not all sugar. It was sucrose specifically, or white sugar, table sugar. Fructose, glucose, lactose, galactose, maltose, no increased risk of breast cancer or cancer, but sucrose, yes. So white table sugar, not a good idea. And, this is reflected in also studies looking at glycemic load. So dietary glycemic load is associated with higher risk of breast cancer specific mortality, all-cause mortality. It's been shown in lung cancer that higher glycemic index, similar, is associated with the increased risk of lung cancer. This is particularly true in never smokers. Colon cancer, this was a very kind of famous in the integrative world now study of stage 3 colon cancer patients receiving conventional treatment. And those patients who were eating a higher glycemic load diet had a significantly worse outcome than patients who were eating a lower glycemic diet. So they were 79% more likely, for example, to experience disease recurrence if they had a higher glycemic load diet. And this was particularly true for overweight patients. So breast cancer, lung cancer, colon cancer. Those are the big ones for glycemic index sugar. In terms of processed food, this is another thing we want to think about when we're thinking about reducing the risk of recurrence. There's a 12% increase in the risk of cancer with every 10% increase in the proportion of ultra-processed food, which we would sort of shorthand as processed food. And this is particularly, again, driven by breast cancer, but true really across the board. In addition to the various chemicals that processed foods contain, the way in which processed foods are prepared increase their carcinogenic potential. For example, the production of acrylamides, which are found in starchy foods cooked at high temperatures like breakfast cereals and French fries, is a carcinogen. Pesticides also have been recognized as a risk factor for cancers of the thyroid, breast, and prostate. So, processed food, you could kind of throw lots of darts at that one and get bullseyes, but definitely something to minimize. Alcohol is definitely a carcinogen. There is about a 40% increased relative risk of breast cancer with moderate to heavy drinking, which is defined as 2 to 5 drinks a day. Drinking up to 1 drink a day does increase the risk of breast cancer by about 6%. That's a relative increased risk. So depending on the starting risk, that's marginally clinically significant, probably not too clinically significant. So, it appears really the clinical impact between alcohol, at least in breast cancer, is going to be at 2 or more drinks a day. And this is particularly important in women who were postmenopausal when they were diagnosed. Premenopausal women, actually, the association with alcohol and breast cancer recurrence risk is not very strong. But for postmenopausal women, meaning postmenopausal at diagnosis, even a half a drink of alcohol per day is associated with increased risk of recurrence. Okay, so dietary patterns, that kind of is all leading us to the Mediterranean diet, which is, lots of whole grains, lots of vegetables, fruits, legumes, fish, nuts, seeds, olive oil, moderate wine. And this, in fact, is associated with reduced risk of cancer, particularly breast cancer. And the inclusion of good quality oils is really an important part of the Mediterranean diet. So the extra virgin olive oil, Oils from nuts and seeds, very important part, as is the fiber. I mean, really, you can't go wrong with the Mediterranean diet. So I know there's a lot of, you know, fancy diets out there or very dramatic diets that people have, you know, some rationale for, but fundamentally, when we're talking about cancer recurrence, we're talking about a diet that people can sustain for 10, 20, 30, 40 years, because that's how long we're looking at trying to reduce their risk. And a Mediterranean diet checks all the boxes. So it's really the diet that I think should be foundational to cancer risk reduction. This is another data point that Western dietary pattern, 46% increased risk of breast cancer, Mediterranean diet, 44% reduced risk of breast cancer. That's quite a difference between those two diets. And the quality of life is improved. This is a colorectal cancer survivor study. And when people eat a Mediterranean style diet, they have better mood, they have better social functioning, and they have less fatigue. This was looking at lung cancer risk, and there was an increased risk of lung cancer in a Western pattern compared to a healthy or prudent pattern, which would be consistent with the Mediterranean diet. And then finally, in prostate cancer, when men follow the World Cancer Research Foundation recommendations, which are pretty consistent again with the Mediterranean style diet, the risk of developing aggressive prostate cancer is much less than in men who do not follow these guidelines. And within the Mediterranean diet, flavonoids are a key component of this. I mentioned fiber, I mentioned oils, but flavonoids really are key. That's the colorful components, the polyphenolic components of the Mediterranean diet. Polyphenols are very protective. They're very significant anti-cancer effects, in part because they inhibit NF-kappa B related inflammation and upregulate NRF2 sort of cell reparative antioxidant pathways in response to stress, which over the long term is going to have an anti-inflammatory effect or an anti-carcinogenic effect. And flavonoids work best together. They're actually, when they're supplemented individually, they're not very effective. When they're given in combination, they're effective. And the best way to get them in combination is to eat them. So when we eat a lot of colorful foods, we're eating a, you know, plethora, thousands of flavonoids, which are synergistically going to augment these anti-inflammatory, anti-carcinogenic effects. Of course, there are some notable standouts. So within this Mediterranean style diet, think about green tea. The catechins or the flavonoids in green tea have been shown to be inversely associated with most cancers. And with breast cancer specifically, in early stage, the higher the consumption of green tea, the less or the lower the risk of recurrence. So at least 5 cups, and this was an average of 8 cups a day, significantly lower recurrence rate than in women who did not drink very much green tea. This has also been shown in prostate cancer. This is a study looking at men with a pre-prostate cancer, sort of like a neoplastic type of condition, which normally goes on to become prostate cancer in about 30%. But with the addition of the green tea capsules, only 3% went on to develop prostate cancer, indicating a cancer preventive effect. And with lung cancer risk, there was also an increase with an increased consumption of green tea, there was a decreased risk of developing lung cancer. And this has also been shown in some other cancers, ovarian cancers, inversely associated with tea intake, biliary, oropharyngeal, ovarian, colorectal cancer. All of these have been shown to have some sensitivity to green tea. So green tea just becomes either something to supplement potentially or to include in the diet. Another standout is soy. The highest intake of soy is associated with a reduced risk of breast cancer. This is particularly true among premenopausal estrogen receptor negative breast cancer, but it's true across the board. Soy does interact with estrogen receptors, but it preferentially binds to the beta receptor, which is an anti-proliferative estrogen receptor. It does not have a pro-proliferative effect. That's old news. So soy is back, as they say. And this has also been shown to be impactful in lung cancer. It's inversely associated with lung cancer risk. So consuming about a quarter of a block of tofu or a cup of edamame a day could actually prevent a third of all lung cancers. That's amazing. Prostate cancer is also inversely associated with soy consumption. And keep in mind, I'm talking about whole soy, not soy isolate, but there we have it. Okay, so in my last few minutes, I'm going to just zip through supplemental nutrients, and I want to just make a case for multivitamins. I'm not generally a big fan of multivitamins, but in fact, there is some good data points to suggest that multivitamin use is correlated with better overall survival in patients with a history of cancer, and that it appears to be a variety of the components of multivitamins that are generating this effect. So when I look for multivitamin, I'm very particular. I look for activated B vitamins because I'm thinking about mitochondrial health and well-being with the methylated, particularly forms of B12 and folic acid. I'm thinking about making sure that my minerals are very absorbable. I don't want just a cheap, salt form of minerals. I want something that's going to really get in there. I want to make sure the multivitamin has glucose control nutrients because of the importance of maintaining good glucose homeostasis. I want to make sure that there's cytochrome P450 supportive nutrients so that the ability to detoxify carcinogens is supported. So B vitamins, zinc, molybdenum, manganese. I don't want any window dressing nutrients. So typically to get enough calcium and magnesium in a multivitamin, it's going to be window dressing. So I'm happy if it's not in there. Or if it is, that recommended dose is several capsules a day. And keep in mind too that multivitamins really only work when they're all the cofactors for these various enzymes that they support are present. So a healthy diet is obviously foundational. Now, within vitamins, though, I have to just spend a moment on vitamin D because this is emerging as a very important way to reduce the risk of cancer. This was looking at colon cancer and the vitamin D level, and you can see that there would be about a 50% projected reduction in the incidence of colon cancer if we had everybody at least 33 nanograms per milliliter serum vitamin D levels. Said another way, there is a 26% decrease in the risk of colorectal cancer for every 10 nanograms per milliliter increase in serum 25-hydroxyvitamin D3. This is just really clear. It's a very linear association, despite all the challenges we have with the inaccuracy of vitamin D measuring. The studies, one after another, are indicating this inverse relationship. This has also been shown with breast cancer. Women with a lower serum vitamin D level at diagnosis tend to be diagnosed with larger tumors. Higher vitamin D levels at diagnosis tend to correlate with improved overall survival, reduced risk of distant metastases, therefore reduced risk of mortality. So having vitamin D at least sufficient is important. But in fact, we now know with studies like this that more is to some extent better. Now, vitamin D is a U-shaped thing, so you don't want to get too high because you start to induce kind of the opposite effects. But I generally shoot for about 40 to 60 nanograms per milliliter as my target for serum vitamin D level, just because of studies like this, which clearly show the benefit really starting to accumulate when we get to that 40 nanogram per milliliter mark and continuing to improve to 60, kind of leveling out past that. So slight decrease, but really this is the kind of sweet spot is 40 to 60. And with lung cancer, we also know that, especially among stage 1B and stage 2B, so kind of earlier stage lung cancer, higher vitamin D is associated with improved overall survival. So that was a whirlwind tour, but I wanted to try to finish early enough to leave some time for questions if there are any. So I'm going to stop my share.
That was a whirlwind, fantastic tour, Lisa. It was really great. How much information you packed into just that sweeping overview. I think that we neglected to say at the beginning that if anybody does have questions, to put them in the chat. We sort of routinely say that, but I don't think we did this time. So I don't see any questions in the chat, but if anybody does right now, please put it in there. But can I start the ball rolling by just asking if you would say a little bit about one of the things I think you were intending to cover as well, which is the patient-practitioner relationship and how important that is in determining outcomes.
Yeah, so I kind of alluded to it a little bit with the slide where I talked about the importance of primary care in treating the whole person and the criticality of that to survivorship. Implied in that, of course, is a therapeutic relationship, but I didn't really address that head on. So there are, in fact, this is let me just step back and say one of the things that's unique about cancer survivors is that these individuals have kind of been through the ringer, and there's something about a diagnosis of cancer that puts your mortality up right in front of your face. And with that comes a high degree of motivation to make changes to lead a healthier, better quality of life. And people need guidance to do that. So if the practitioner steps into that space in a supportive, humanistic way and, really recognizes and nurtures that sense of, that embrace of life that these people have, I think there's really no end to the good that can come from that relationship. So, I would say this is a population of individuals that are a little bit more sensitive in some ways, but also more open, more they're fun to work with because they are so motivated. So it's a really rejuvenating way to a group of patients actually in one's practice.
Thank you.
Okay.
Amy, can
Yep.
you
We do
read
have
any questions?
questions in the chat. First of all, we have lots of people saying thank you for the presentation and that it was great and very informative. We just have a couple questions asking for access to the slides. And
Yeah, I'll send them to Peter. Who should I send them to? I'll send them just email me and I'll email you back with the link and you can send them out. That's fine.
Great, thank you so much.
share that this presentation will be on the AIHM YouTube site. So it is recorded and will be shared as well if you want to go back and watch any part of the presentation also.
Right, and we will, since you have all registered to be here tonight, we're going to send you a notification specifically and a direct link to the talk when it is available.
And I will send my slides as soon as we finish so you guys can distribute them.
Thank you so much. Are there any last questions before we say goodnight? Okay, well, thank you so very much. That was wonderful. We really appreciate your time and expertise. And
Absolutely.
Lisa, thank you. Elise, thank you so much. I second that. I third it. It was great. I really
Good.
appreciate your time. And you were talking about organizational skills. That's one of the best organized talks that I've heard. So, oftentimes, we have great speakers a lot of the time. Sometimes, they get a little rambling and stuff.
Mhm.
Yours was so focused. It was like incredibly